Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I'm very excited to be here, and some of you may know this is a very personal, passionate topic for me. I am a Native American, and I grew up on actually an Indian reserve in Canada, but I've personally been impacted by obesity as a child, and my family, of course, as well as diabetes. So I'm very happy to share my passion for this field. I don't have any disclosures. We are going to today just generally talk about obesity, and just so you know, I feel the weight, and I know Dr. Wood had wanted me to kind of talk about the treatments, but in order to understand the treatments, we really need to know about that pathophysiology. Otherwise, I think for context, you just have to know that background. Another disclaimer here. So obesity in patients with HIV, the incidence, just like the general population, obesity is rising as we speak. Some antiretroviral therapy, of course, is also weight promoting. And we know obesity can increase cardiometabolic risk as well as cancer. And because patients with HIV are at a much higher metabolic risk, when we combine these two, it's a very obvious, serious issue that we want to help address so we can reduce that risk. Before we kind of get into kind of physiology and the treatments, I think it's important just to acknowledge that, weight stigma is still something that, is very common in healthcare and in our society. And in particular, research has shown that patients are less likely to undergo even preventative cancer screening because of weight stigma. A study by Amy et al. Surveyed some patients, about 498 with overweight and obesity, and 83% reported that their weight was a barrier to get appropriate health care. We know weight stigma does cause physical and psychological harm, and what can happen because of stigma is that we internalize those biases and things and blame ourselves. And when we take on that, again, internalized weight bias, that does lead to depression, anxiety, social isolation. And we just see that stress that people take on because of that can actually lead to more, poor metabolic health outcomes, more weight gain over time. And it's important to note that weight stigma is prevalent among, people of diverse ages and background, and it does affect our, public health policies and access to treatment and research. It's not based on science, so oversimplifying weight loss as, eat less, exercise more, it's important to note that is a form of weight stigma. Adults and children who experience weight-based stigma are more likely to avoid exercise, engage in unhealthy eating behaviors like binge eating, again, which leads to just more weight gain over time. So we really have to, understand that that's happening potentially for our patients. So I really appreciate the information that I've received from your program and, your patient-first ways of speaking about HIV. And the same thing would apply to obesity. So we want to use patient-first language, patient, with obesity, not obese patient. Weight in particular, there can be many other things, like stigma and things that may be attached that our patients are taking in. So it's really important that you want to ask permission to talk about weight, and never, ever, ever use just a BMI or weight alone to evaluate health. Many times I have patients coming in, they're like, I need to get to this, BMI to be healthy. BMI does not account for muscle mass. It doesn't account for any of the metabolic changes we see. It's just really a screen. Like, in patients in certain ranges, maybe we want to evaluate further, but it's never a goal that I would have any patient try to aim for. And just alone, it's not a good indicator of health. So this image here, I think, really kind of puts in perspective, hopefully for you, but, when I look at it, but also sharing with patients. When we do gain weight and get to our highest weight, unfortunately, our body is going to remember that weight forever. And we, in obesity medicine, refer to that as a set point. And right now, there is no treatment, no surgery, no medication, supplement that I can give a patient to help reset that. So as we proceed with, weight management, we really have to kind of understand this concept. So as our weight reduces and the body, again, is remembering our highest weight, the metabolism slows down. So metabolism, as we lose weight, and the more weight we lose, that metabolism is just going to, slow even more. And again, there is no medication, no supplement, no injection, surgery that I can recommend that can reset metabolism. So we have to understand the body's going to remember highest weight, metabolism is going to slow down. We also know that during weight loss, in terms of this adaptation, our stomach increases production of our hunger hormone called ghrelin. So with weight loss, the ghrelin starts rising. And even years after weight loss, research shows that ghrelin will stay elevated even years after weight loss. The other change that happens, and we're going to talk about this as we talk about the treatments, but when we eat food and the food hits our small intestine, there are several hormones that our gut releases to help regulate our appetite and specifically help with satiety. So when that food hits the gut, it goes to the brain and says there's food, and we stop eating. These hormones also play a role in regulating insulin in the pancreas. So those satiety hormones also become dysregulated. So we've got set point, body trying to pull us back, ghrelin going up, our satiety hormones reducing. So as you can see, again, and from what I've just mentioned, the body is really resisting that weight loss because it wants to, again, push us back to that set point. And just to reiterate, more weight we lose, the more the metabolism slows down. And once you get to the goal weight, your metabolism, again, it's not going to go back to your previous weight. So when I lay this out for patients, I always say, it's important that our plan has to be for life, long term, and that applies to our treatments that we're going to talk about. Again, these are not just like, treat for 6 months and then you're good to go. It's going to be kind of a constant battle that we have to do to navigate through these challenges. And we can, and with the tools we have, we can get sustainable long-term weight loss. This is just another piece that I like to go over with patients when we talk about the medications and how they work and just obesity as a disease. One of the challenges that we also have to navigate through is that when we do increase weight through weight gain, our body does increase the adipose tissue or the fat cells. And what's surprising, I think, for patients to understand is that our fat tissue in the body is actually a very hormonal organ, and it's comprised of billions of fat cells. So when we get this weight gain going up, these fat cells, we start getting more, and they start to become very dysfunctional. And in particular, one of the things that happens is the fat cells will start kind of expanding as they're storing fat. And that fat cell, it secretes inflammatory factors. It secretes tumor factor. We know that there is, several types of cancers that can be associated with obesity because of that dysfunctional fat tissue that's going on. But these fat cells, as they're kind of growing and replicating, they are also driving the body into this insulin-resistant state. And then on the picture on the left here kind of shows you, when we get more and more of this fat cell being produced, and we really run out of space to store all of this new adipose tissue. It's, enlarging and replicating. So some of it spills into the bloodstream, and that can affect our cholesterol because the liver has to process that, and we end up seeing triglycerides going up, HDL going down. But then the body will then start storing the fat around the internal organs, and we start seeing more central weight, inflammation around the cardiovascular system, blood pressure starts going up, a higher risk of heart attack and stroke. So for health, really super, important to understand this, because this is, in terms of obesity, this what drives the health risk. But when we develop our strategy and our plan for patients, we just have to be able to address this issue because otherwise the body just wants to keep storing and holding on to the fat. So as we kind of proceed now to talk a little bit about treatments, I think it's really important to go over, realistic weight loss goals, but also, what goals are going to help for health, because that's why we do this obesity medicine. We're treating health. I know there's a lot of external, pressures, societal pressures for weight, but, we are doing this for health. And the good thing is we have some guidance, our endocrinology guidelines on obesity really break this down nicely in this chart showing, based on which health issue a patient may be dealing with, what percentage of weight is going to have a health benefit. And across the board, you can kind of see most health issues will have a significant benefit even at 10% weight loss. 5% is going to be, even great for cholesterol, for blood pressure. But if we can get 10, again, that's going to be more optimal. For things like liver disease and diabetes, we might even want closer to 15 for maximal benefit. So we don't have to go to that, again, perfect BMI. Even small percentages of weight can have a huge benefit. And the other thing we need to think about when we talk about these treatments is, what are their, limitations, and like what kind of weight loss can we usually achieve? So most times when patients lose weight, like they are eating less, exercising more, that type of, behavioral change, they will lose about 2 to 5%. When we do more intensive nutritional therapies like Noom or Weight Watchers or, seeing a dietitian, we can see between 5 to 10% weight loss. When we start adding pharmacotherapy, we are able to kind of push this, and the medicines are getting stronger and stronger, as we'll discuss, but, we may be able to get up to 20%. Endoscopic therapies are something that are kind of on the rise. We don't do them at UW, at least yet, but, they can achieve a fairly good amount of weight loss. But metabolic surgery, like if we have, major health comorbidities that we want, greater percentages than 15, like maybe NASH or things, surgery is definitely going to be the better tool to get more weight loss. So who can be considered for anti-obesity treatment? And we've got medical and surgical. So for medical, BMI, unfortunately we go by BMI, but if you have a BMI greater or and equal to 27 with an obesity-related comorbidity, you could be considered, or if you have a BMI over 30 without a comorbidity. And then for surgery, if you have a BMI greater than or equal to 35 with severe comorbidity, you may qualify, or if you have a BMI over 40 without comorbidity. But even for both of these, guidelines, there are kind of adjusted BMIs for Asian population. Asian American, even at BMI over 23, there can be elevated risks. So we definitely have to, these are not kind of perfect numbers when we look at, the cutoffs, again, for Asian American. And I mentioned this last point, surgery can possibly change set point. Well, when we talked at the beginning, I have no pill, no injection that can change set point or metabolism. And surgery doesn't do that either. But what people don't know compared to the medications is surgery does, by reducing the size of the stomach, it does help obviously with a calorie restriction, but it reduces the ghrelin, that hunger hormone that I mentioned that rises. So it's going to do that in a more permanent way. But also a bypass or sleeve, it's going to increase that GLP, those gut hormones that I mentioned that help with fullness and insulin resistance. And it's a tool that, can possibly treat diabetes. So, it doesn't change metabolism, but it does give patients more permanent kind of reset of some of these hormones to help them, have long-term weight maintenance. And just kind of a slide, surgery is not just a last resort. It can really, improve and if not resolve many issues like diabetes in particular, before, after, like it's as close to, I guess, a cure if we have one. So medical treatment of obesity. So the FDA has approved the following pills for treatment of obesity. We have the bupropion extended release and the naltrexone extended release. We also have the orlistat, or otherwise known as the Ally or Xenical. And then we've got phentermine topiramate extended release. And we also have 3 injectables. So the one is on here because I'm going to talk about the other ones in the other slides, but liraglutide, which is the daily injection, is also approved. So we've got those 3 pills, plus we've got the, liraglutide and the other 2, which I'm going to talk about. But I put this up here like this to show you kind of also limitations of treatment, because they're not all created equal. And if you're treating someone, I wouldn't expect that, they're going to lose 20-25% of their body weight. But typically, based on this randomized control trial studies with patients BMI 35 to 39, patients may lose on average with bupropion naltrexone about 8.1%. The liraglutide, which is the daily injection, about 9.2%. The orlistat, 8.78%. And then the phentermine topiramate is going to be kind of the stronger one. Patients may lose at the moderate dose 9.6 up to 12.4. And just before we move on, just in terms of mechanism, so all the meds reduce appetite. So, and again, surgery also reduce appetite. And we need to have that calorie restriction in order to counteract that slower metabolism. So that's the rationale why we need something to control appetite. Bupropion and naltrexone has a nice effect in dopamine and that reward pathway, so it's very helpful for kind of emotional eating. The phentermine is a stimulant, so it's in the same class of medicines as like the ADHD medications, but it works nicely to reduce appetite. And the topiramate, which is combined with it, used commonly for migraines or seizures, that has a nice effect also in the dopamine reward pathway as well. And we actually don't know all the ways it works for weight loss, but it may have some metabolic benefit. The orlistat basically decreases fat absorption, and every time I look at this, I'm so surprised about the weight loss, but it doesn't really do anything for appetite. It really just decreases the body's how it absorbs fat. So people usually get like a lot of GI side effects and things. And then the liraglutide we're going to talk about in a bit with the other ones, but it's going to work more in the gut. And I want to introduce you, before we get into that, with this concept, and this is really where the future of obesity treatments are lying. I mentioned at the beginning, when we eat food and that food hits our lower in our intestine, there are several hormones that get released that go to the brain, they go to the pancreas, they help regulate insulin. And I'm not going to go through this hugely complex picture, but there's just so many hormones. And everyone is probably familiar with this GLP-1 hormone, which we're going to talk about for weight loss, but there's many. Like, we're just at really the tip of the iceberg in terms of where we could possibly go with our treatments. So we've coined this word in obesity medicine, nutrient-stimulating therapies, because those are those hormones that get secreted when we eat foods. And again, they basically help with, our intake, but also regulating insulin. So one of those nutrient hormones is GLP-1. And the medications that we have that are injectables, we've got 2 of them. They basically help, they're receptor analogs. So they help, increase the action of this GLP-1 hormone. The liraglutide is the daily injection that we've talked about, and all of the trials that are related to that are called the SCALE trials. And each one of these medicines, you'll see they have their own name coined, and that's the series of studies that show you, what is the percent weight loss and in what population. But the liraglutide studies do show an average weight loss of about 8% versus 2.6% placebo. And in diabetes in particular, weight loss is about 6% versus 2%. As you'll see, there are differences when patients actually go on and have diabetes. Even with bariatric surgery, the weight loss is not as high as someone without diabetes. So we definitely see that with the medications. The semaglutide is a weekly injection, and all of the trials related to semaglutide are called the STEP trials. But basically, at 68 weeks versus placebo, patients did lose 14.9% versus 2.4% placebo. And the extension of those trials where they follow patients and then randomize to stop or stay on, they did find that by 120 weeks, those that stopped, they regained about 11.6% of their body weight. So again, these medicines are not permanent, although people did keep some of that weight, off long term. In diabetes, average weight loss was 9.6 versus 3.4%. And many of us have seen this data come out recently, but there's another series of trials for heart disease and stroke. And the high-dose semaglutide was associated, when we used it in patients who had cardiovascular disease and obesity, they found a 20% reduction risk in all major cardiovascular events in those patients with established cardiovascular disease. And just in terms of use with an HIV, I know Dr. Wood shared some, conference information about, it seems like it's really a growing kind of research niche because of obviously the cardiovascular risk with our patients with HIV. But this observational study looked at, and it was, patients who had diabetes, some who had diabetes. So it was kind of a mixed population, but on average, age was about, 53, a lot of males, which is good. because what we've seen is that a lot of those other trials, they really didn't include very many patients of the male sex. It was mostly female sex. Average weight in this observational study was about 108 kilograms, BMI 35.5. And again, some of them had diabetes, and actually 77% of those patients did have type 2 diabetes. And there were a good chunk of them who were on these integrase strand transfer inhibitors, which caused the most weight gain. But overall, what this observational study showed is that, even at really low doses of semaglutide, and they looked at oral, injectable, but even low doses did have a meaningful weight loss, of at least 5%. So average weight loss 6.47% at 1 year. And those patients who were on those more weight-promoting treatments, there was very similar weight loss. So semaglutide can have very meaningful benefits for weight loss, even at low doses. What about our kind of new treatment that I think a lot of us are hearing about? And when we looked at that slide earlier, all of the gut hormones. So our newest treatment is a GLP-1 receptor analog and something called the GIP receptor analog. And GLP, like we've talked, helps with satiety, but it also helps regulate insulin. And GIP just seems to augment that effect of the GLP hormone. So it has, many other things, but it just augments that effect and we get greater weight loss. And the SURMOUNT trials are all of the trials related to the tirzepatide. But even as little as 5 milligrams, 10, 15, patients lost a lot of weight, like 15%, 20%. So really, really strong percentages of weight loss, obviously for health versus placebo. Diabetes, they still lost a lot of weight, but patients with diabetes still had, not as much as patients without. But also when they randomized patients to stop, there was weight regain. So I wanted to just illustrate this is still not going to reset the set point. Very, very important. And I think when Dr. Wood shared some of the conference data, this was mentioned in patients with HIV and semaglutide, but they lost muscle mass. And that's the concern for anyone when we treat with these medicines because they don't feel hungry, at least initially. And our muscle is the most important thing in our body that helps determine our metabolic rate. So we want to preserve it. So I think working with a dietitian is incredibly important when patients are on these medicines to make sure that they get enough protein. We sometimes will even do like protein shakes and things. But again, from the data that maybe Dr. Wood will mention this, it seems like there was definitely a good amount of muscle wasting in patients who were treated with the semaglutide. The coverage. It's, unfortunately, this is the worst part of, my job. We've got all these treatments, but not everyone has access to them. If patients have type 2 diabetes, of course, they may have coverage, but they may not have coverage for the semaglutide or the tirzepatide, but they may have coverage. I mentioned here, I could have went on and on talking more about this too, but metformin, I think, is a really great, cheap alternative, and patients still get meaningful weight loss with that too at about 5%. Just be very cautious. Also, we didn't talk about this also, but disordered eating is very common in patients with obesity, and sometimes, when we just throw these meds at them, that can kind of make it harder for them to, do the behavioral therapy they may need to help regulate their eating patterns. And also vitamin deficiencies are very common with obesity. Vitamin D, the fat tissue seems to reduce how the vitamin D is activated. B1 or thiamine, our body just uses much more of that in an insulin-resistant state, so that's another one that can be quite low. But also some of the meds will reduce absorption of B12, so just be on the alert for those, and you may want to monitor them. So obesity management, never rely on BMI. It needs to be, we need long-term sustainable, obviously lifestyle habits. And the medications are an adjunct to the lifestyle, but they need to be continued long-term in order to sustain the weight loss. And again, even at low doses of the semaglutide, there was huge benefit, meaningful weight loss for patients on an antiretroviral treatment. And just, again, be aware of the, internalized weight bias and stigma, because sometimes even adding therapy for patients can be really helpful to kind of navigate through that. I appreciate your attention. Thank you so much.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.